there are several cases. Most of them are focusing on vessel wall imaging, the stroke cases, and we are fortunate that we have amongst us online on Dr. Rajsrinivas Parthasarathy. He is a senior consultant neurologist and neurointerventionist. He will speak on vessel wall imaging, how it should be done, what are the radiological parameters that may influence the vessel wall imaging, and how best we can use this state-of-the-art MR technology for diagnosing several conditions related to stroke like CNS vasculitis, dissection, RCVS, MOA, etc.
Times the reporting is not correct, and patients may have an incorrect diagnosis, and sometimes patients are put on long-term steroids when it probably isn't required. So I have appropriately termed it as false positive reporting of vasculitis in vessel wall MRI, because many times it's reported as vasculitis when it is not. To understand this, first we will discuss a case, and then we will go through the pathology, then pathogenesis, and based on the pathology and pathogenesis, what the vessel wall MRI will look like in different conditions. So let's look at this 39-year-old male with no risk factors, had a right MCS stroke. This is the angiography which shows there is an M1 stenosis here. He had left subclavian stenosis also and bilateral renal artery stenosis. So this patient underwent a vessel wall MRI elsewhere, where it was reported as near concentric enhancement. If you see in this particular So if you look at this one here, so they mentioned that it's a 3/4 sort of circumferential enhancement, and they decided it is vasculitis, and this patient was started on steroids. So the question really here is it vasculitis or atherosclerosis? And to answer this question, we have to go through the entire sort of pathology, pathogenesis of various conditions, and then finally we'll come to this case to know whether this is vasculitis, whether we are right in starting steroids in this particular patient or not. So very briefly on the technical aspects. So the vessel wall itself is 0.2 to 0.3 millimeter. So only in disease status we'll be able to look at the vessel wall, meaning for the MRI to be able to look at the vessel wall, we need at least a minimum thickness of 0.4 millimeter. So we want to have the signal from the wall of the artery, but suppress the signal from within the artery and outside the artery. So outside the artery you have the CSF, we want to suppress that. And within the artery we have blood, so it is called as a black blood sequence. So we generally want to use a 3 Tesla MRI, and we want to image in multiple planes and multiple tissue weightings. When I mean multiple tissue weightings, we want to have the T1 sequence as well as the T2 sequence. Nowadays we do have the 3D technology, so we can sort of look at the entire vasculature. So we have the T1 axial, sagittal and coronal sequences, pre and post contrast, as well as the T2 sequences that we want to have a look at, to really look at certain features which will clinch the diagnosis. So the question is, why do we really need to do it? So as the previous speaker clearly mentioned, we want to differentiate what is the cause for this narrowing in this particular young stroke, and to be able to see the not so obvious. And in some patients, if the patient has vasculitis, can we really assess disease activity? And can we really see if there is any response to treatment? So this is a very interesting paper that was published, which looked at whether adding a vessel wall imaging really makes a difference to the diagnosis, making the diagnosis. So what they have concluded was that the correct diagnosis rates really jumps from less than 40% to close to 90%. So therefore, there is a clear need to understand this imaging modality and apply in practice. And again, the agreement between two raters. So without vessel wall imaging, there was a very poor agreement between two raters of 0.02, and this came up to 0.72 when we added vessel wall imaging to luminal imaging. So this paper clearly says that vessel wall imaging is important to be able to differentiate the different possible etiologies. So what are the etiologies that we are going to discuss? One, of course, is the normal vessel. In moya, what happens is the intima thickens, whereas the media atrophy. So if you see here, the intimal layers have thickened, but the media is atrophic. And it is called as negative remodeling because if you compare with a normal vessel, the outer diameter of the vessel has reduced. So this is called as negatively remodeled artery. Now look at this condition. This is vasculitis, where all three layers, intima, media, and the adventitia, are involved. All three layers increase in diameter, but overall the vessel size doesn't really change much. And the lumen is narrow. So the lumen is narrow, inflammation is transmural, and the internal elastic lamina is broken. Therefore, the contrast seeps into the medial layer. In reversible cerebral vasoconstriction, the lumen is narrow. The media is thickened multifold. If you see, the media is very thickened here. And there is actually no inflammation of the vessel wall, but you may see some grade 1 enhancement in RCVS. When you come to atherosclerosis, the lumen can be variable. The narrow is usually eccentric, and there can be inflammation in the plaque. So this is the brief overview of the different pathologies that go on with the different causes. So what happens in intracranial atherosclerotic disease? The first step in intracranial atherosclerotic disease is wall thickening. It can be due to hypertension, aging, whatever the cause is, the wall thickens. As soon as the wall thickens, you need blood flow to the arterial wall. Therefore, the vasoviscerum forms. And this promotes atherosclerosis. So we need to know a little bit about the vasoviscera. So if you look at this artery on the left-hand side, you see the internal elastic lamina in this artery is very well developed on the artery X. But when you look at the artery Y, there's no internal elastic lamina at all. And the external elastic lamina is absent in artery X, but very well seen in artery Y. And if you see, there is no vasoviscera in the adventitia in artery X, but if you see here, there is vasoviscera. So clearly, the artery X is an intracranial artery, meaning there's internal elastic lamina, but there is no external elastic lamina. Whereas an extracranial artery will not have internal elastic lamina, but have an external elastic lamina. And vasoviscerum is absent in the intracranial arteries. So the nutrition to the wall of the artery is from the blood as well as from the CSF. So the intracranial circulation is devoid of vasoviscera, but with age and disease status, the vasoviscerum can be there. And the role of the vasoviscera is nutritive. So only if there is a very thick medial layer, more than 29 muscular layers, we can see vasoviscera, or if the thickness of the media is more than 350 micron. So you can sometimes see vasoviscera in the proximal segment of the intracranial arteries up to 1.5 centimeter or so. So what really determines vasoviscerum? The medial thickness, and if there is luminal hypoxemia, that also triggers the formation of vasoviscera. And there are two types of vasoviscera, vasoviscera interna and vasoviscera externa, which I'm not going to go into details. So coming into ICAD, so there are two types of remodeling patterns. Why do we need all this information? Then only we'll be able to confidently say whether it is ICAD or vasculitis. If you understand which segment of the artery can be involved with atherosclerosis more commonly than vasculitis, what will be the pattern of involvement of the arterial wall. So for all those things, I think it is important to go through these topics. So remodeling can be either positive or negative. What does positive remodeling mean? In this particular condition, the lumen does not narrow down. So you will not be able to identify on luminal imaging. So 37% of intracranial atherosclerotic plaques cannot be assessed angiographically, meaning you do an angiography, the artery looks normal, but there is a plaque within the wall of the artery. And if you have a positively remodeled artery, there's a 5-fold higher probability of it being symptomatic. So let's look at two important vessel parameters. One is the vessel area, that is the outer diameter of the artery, and the other one is the lumen area that looks at the luminal side. So the difference between the vessel area, which is the outer diameter, and the lumen area gives what is called as the plaque size. So why is it important? So this is a positively remodeled artery. So you compare two sides, the lesion site with the reference site. So this is the lesion site. If you see, the outer diameter of the artery is bigger than the diameter of the artery at the reference site, meaning the ratio of the diameter at the lesion site is more than that of the reference site, and the ratio is more than 1.05. If you see, the plaque burden is quite a lot, but the lumen is relatively preserved. So this is a positively remodeled artery, which is a high risk plaque and high risk of stroke, and it will not be seen on your CT angiography and DSA. What is negatively remodeled artery? You see at the lesion site, the diameter, outer diameter of the artery is smaller as compared to the diameter of the reference site. So the ratio is less than 1. You see the plaque is not as big as in a positively remodeled artery, and the lumen is narrowed down. So this is the key difference between the two types of remodeling, and we will discuss how this causes the stroke. So what happens initially when plaque deposits in the wall of the artery? So if you see here, initially the outer diameter of the artery keeps increasing, but if you see the lumen is maintained, there's no change in the lumen up to a certain plaque size. And this enlargement in the outer diameter of the artery is called as a compensatory over-enlargement of the artery. So initially there is no compromise in the lumen size at all, but beyond a particular level of plaque size, the lumen starts going down. So initially it's a positively remodeled plaque. Later on, once the lumen goes down, the fibrosis of the plaque also occurs. Overall, the artery shrinks and becomes a negatively remodeled artery. In coronary artery, you need a 40% plaque size to see some change in the luminal size. In the internal carotid artery, you need a 65% plaque burden, meaning a lot of these arteries which look normal to you, there may be a plaque, and this type of a plaque is a more aggressive plaque, and therefore we need to have some imaging way to look at whether these patients, all these cryptogenic strokes we call, may be having a plaque which is positively remodeled and we are not aware of it. And in the basilar artery, we need a 50% or more plaque burden to be able to cause a stroke. So what is the type of remodeling? Is there a predilection to the circulation? If you see here, there is more positive remodeling in the posterior circulation and a negative remodeling in the anterior circulation. As neurointerventionists, we need to know about this because in the anterior circulation, when we do balloon angioplasty, in a negatively remodeled artery, the outer diameter itself is narrow compared to the reference site. So what happens is, if you do more aggressive angioplasty, there's a risk of rupture of the vessel and leakage of hemorrhage. So let's look at a negatively remodeled artery. This is the M1 stenosis here. Now, this imaging is at the reference site, and this is the lesion site. And if you clearly see here, there is eccentric thickening and a width grade 2 enhancement. So this we know it's a plaque which is sitting there. But now look at this image here at the bottom. So if you see, this is the reference site, this is the lesion site. The outer diameter, which is represented by the green here, is definitely reduced here, and the lumen is also narrowed down. So this goes for a negatively remodeled plaque. Look at this basilar artery. I told you that posterior circulation, more positive remodeling. You will not really see lumen narrowing. When you see lumen narrowing, it means more than 50 to 60% plaque size is there. So the lumen is maintained. There is a plaque here. And if you look at this is the reference site and this is the lesion site. And the green represents the outer diameter and the red represents the lumen. So the lumen is relatively preserved. And the outer diameter, in fact, is bigger in the lesion site as compared to the reference site. So this goes for a positively remodeled plaque. So it can help reclassify cryptogenic strokes because many times we are not able to appreciate on luminal imaging. Unless we do a higher imaging modality, we are not going to identify it. So we know that expansive remodeling or positively remodeled arteries, they are much higher chance of being symptomatic as compared to constrictive remodeling, which is a negatively remodeled artery. The chances of stroke is less. And a positively remodeled artery has much higher chances of intraplaque hemorrhage, which is a risk factor for stroke, inflammation, and microembolic signals. Now, when you look at the vessel wall MRI, when we are planning, I'm coming to the imaging features in a moment, we need to know which wall of the artery is involved with the plaque. So look at this middle cerebral artery here. Any artery can be the middle cerebral artery can be divided into 4 quadrants here: the ventral, the dorsal, the superior, and inferior. So depending upon which wall the plaque is, we will know what is the risk of a procedure. Say, for example, patient has ICAD, hemodynamically significant stenosis, a recurrent stroke despite treatment, and we want to do a balloon angioplasty and stenting. We need to decide on which wall the plaque is. Why is that? If you have a plaque in the anterior and inferior wall, the chances of a per-operative stroke is less. When you're doing a balloon angioplasty, what happens is the plaque can be pushed into the ostium of the perforator and cause a stroke. Whereas if the plaque is in the anterior and superior wall, the perforators are coming from the superior wall. So whenever there's a plaque is involved in the anterior and superior wall, the chances of stroke, per-operative perforator occlusions are much higher. So the vessel wall MRI helps us in identifying the site of the plaque and procedural risk as well. In basilar artery, it tends to occur in the anterior wall. And we also talked about why it causes more positive remodeling. We think that it is because of the lack of sympathetics in the posterior circulation. If you see, all these hypoperfusion risk is almost always in the anterior circulation and not in the posterior circulation. Even if you see post-subarachnoid hemorrhage, we see vasospasm involving the anterior circulation and not the posterior circulation. So there is some difference between the autonomic distribution in the anterior and posterior circulation, and I feel that one of the reasons why the posterior circulation is positively remodeled is because of the lack of sympathetics and low wall shear stress, which is more common in the posterior circulation. Here we have the perforators in the lateral wall, but if you see here, the plaque tends to occur in the anterior wall of the basilar artery. So from the coronary literature, we've also come to know which wall is more predisposed to forming a plaque. So look at this left anterior descending artery. This is the left circumflex artery. So the plaque tends to occur in the wall opposite to the side branch takeoff. And this is very, very important for us, particularly when we are treating these patients interventionally, because we know most times than not, it is opposite to the site of the perforator origin. They've gone to the extent of looking, depending upon the takeoff angle. Say, for example, this is a perpendicular takeoff. The plaque forms in the wall opposite to the takeoff. Sometimes the angle of the artery can be clockwise, and then the plaque forms ipsilateral to the angle takeoff, and it can be anti-clockwise, and it is along ipsilateral to the side to which the takeoff is. So a lot is to be understood, because why this predisposition to a particular pattern or particular wall the plaque is occurring. And that will be explained by flow dynamics. I'm sorry it is a very busy slide, but I will try to make it as simple as possible. So this is the common carotid artery. This is the internal carotid artery, and this is the external carotid artery. So this is the flow divider. So the jet is going to hit this and get diverted. So this jet from the common carotid artery enters the internal carotid artery. This point here, S, which is marked, is called as the separation point. That means beyond this point, there's no contact between this jet and the wall of the internal carotid artery. So it creates what is called as a dead space here. So the blood from somewhere else has to come into this dead space, and the jet that hits the flow divider, that's a very high velocity jet. We know the flow in the arteries are streamlined. The central flow is high velocity jet, and the peripheral flow is a low velocity jet. So this high velocity jet hits the flow divider, comes to this dead space area, goes backward, and then turns and then enters the central circulation. Similarly, there is a helical flow pattern that we observe that goes into the dead space and goes antegrade. And this zone is called as the residence zone. Whenever we do a DSA, we see this stagnant flow beyond in the carotid belt. And this is the flow dynamics that explains it. So one more thing we need to keep in mind is high velocity jet is a high shear and low velocity jet is a low shear. So this is a high velocity flow that is hitting the flow divider. And then as it reaches the space, the velocity really drops. If you see, the velocity is 24.7 centimeters per second. Here it was around millimeters per second, and here it was around 583 millimeters per second. So clearly the velocity really drops. Because the velocity drops, the shear also drops. The shear stress is extremely low here. And the problematic one is not the high shear, it is the low shear which causes the problem. The low shear is causing positively remodeled plaques. So, and if you see here, the plaque almost always forms in the outer wall of the internal carotid artery and the outer wall of the external carotid artery. So let's look at these examples here. So this is the common carotid artery, this is the external carotid artery, this is the internal carotid artery. This is the flow divider here. So the plaque is forming on the outer wall of the internal carotid artery. Similarly, if you see, this is the external carotid artery, this is the internal carotid artery. Again, the plaque forms on the outer sides of the internal carotid and the external carotid artery. What if there is a turn in the middle cerebral artery? Many patients I see, there is no risk factors, but they have atherosclerosis. So your arterial anatomy and curvature plays an important role in patients developing atherosclerosis. So if you see here, this is the curve here. So whenever this jet is going like this, the high velocity jet will hit here. But as the blood flows like this, there is a dead space that will be created here. There will be a very low velocity jet, low shear stress, and the plaque tends to form on this wall. So there are two types of stress that you need to understand. One is the normal stress, which is perpendicular to the wall of the artery, and the other one is shear stress, which is tangential to the wall of the artery. So again, I'm going to repeat, wall shear stress, if it is low, it is the more problematic one. The TNF and interleukins are raised, and high-risk plaque feature, it is a positively remodeled plaque. The plaque tends to rupture and embolize. Whereas if the wall shear stress is very high, it inhibits TNF and interleukin 1b. This is not a positively remodeled plaque. This is a stable plaque. It's a fibrocalcific plaque. It is not. It is already healed plaque. The mechanism of stroke in positively remodeled plaque, and this is quite different. So 2/3 of strokes are due to positive remodeling, which means a high-risk plaque, the plaque ruptures and causes a stroke, and 1/3 it is due to high wall shear stress. This is a fibrocalcific plaque. The artery is narrowed down, endothelium is eroded, thrombus forms on the surface of the plaque, and that embolizes. Now coming on to now that we have discussed the pathology and pathogenesis of ICAD, we're going into the vessel wall MRI. So if you look at the plaque, so you have what is called as a fibrous cap. This will appear right on T2. So for example, if you look at this artery here, this is the outer diameter. So you see this T2 bright structure here, and this represents the fibrous cap. The blue one here represents the fibrous cap. And below that, you have the lipid core. So normally on T1 and T2, lipid appears bright. But if you see here, this is appearing dark here. So the difference between this, the content of this lipid and the other one is that this contains cholesterol and cholesterol esters and not triglycerides. The cholesterol and cholesterol esters appear T2 hypointense. Okay, so look at this plaque here. This is the lipid core. Now look at this one. This is the lumen. The red one is the lumen here. This is the outer diameter of the artery. Now there is a break in the fibrous cap, and the lipid content is exposed, and that causes clot formation and embolism. So this has already been discussed. So what happens is the fibrous cap tends to enhance. This is the lipid layer, and the outer layer, which is the adventitia, which this is the proximal internal carotid artery, can have vasovasorum, and that can also enhance. So one other thing we need to look at is also the plain T1 before contrast enhancement. If you see there is a stroke here, this is the M1 stenosis that you see. But if you see here, there is some, this is the T2 sequence. If you see there is a T2 hyperintensity, this is the fibrous cap, and there is pre-contrast T1 brightness in the wall of the artery. This represents intramural hemorrhage, or there is an intraplaque hemorrhage, which again suggests that it is a high-risk plaque. Now, looking at the grade of enhancement, we always compare it with the pituitary stalk. If the grade of enhancement is as that of the pituitary stalk, it is a grade 2 enhancement. If it is not there, then it's a grade 0, and anything in between is called as a grade 1 enhancement. And depending upon the enhancement grade, so if there is no enhancement at all, it is considered to be a non-culprit lesion. It is unlikely that it has caused a stroke. But if there is enhancement in 2/3 of patients, it tends to be the culprit for the cause, culprit for the stroke. So no enhancement means not a culprit lesion. Culprit lesion tended to have a grade 2 enhancement, and I mentioned grade 2 enhancement is almost to that of a pituitary stalk. So what did we learn? We learned about flow dynamics. We learned that low velocity means low shear. Low shear means it tends to cause positively remodeled plaque. Positively remodeled plaque means the lumen size is maintained, and the cause of stroke is a plaque rupture and embolism of the material. And in negatively remodeled plaques, it's a fibrocalcific plaque. The endothelium is denuded, clot forms on the wall of the artery and is embolized. We looked at a fibrous cap, which is a T2 bright structure, which is juxtaluminal. The lipid itself is a cholesterol and cholesterol ester, which appears hypointense on T2 imaging, and the vasoviscera and the fibrous cap can enhance. Now, moving on to vasculitis, it is usually a smooth concentric wall enhancement with thickening. So it's concentric. But we will see some cases where vasculitis can be 3/4 concentric. Some cases where you see atherosclerosis where it is almost concentric. So there is always an overlap between atherosclerosis and vasculitis, and that's where the confusion arises, and that's why the rates of false reportings. So what happens is there is increased permeability of the endothelium with contrast leakage from the lumen into the arterial wall, and there can be vasovisceral related contrast leakage as well. This was already discussed. If you see here, there's a concentric enhancement here, and if you see the PCA is also enhancing, the basilar artery is also enhancing. And it can be short segment unilateral, it can be bilateral, it can be single artery or multiple vessels, and it can extend into the periadventitial tissues. So one of the important things is the median duration of enhancement is 7 months. So in vasculitis, the enhancement, I have seen it up to 12 months. So it doesn't really tell us much about the disease status. Whereas in atherosclerosis, the enhancement usually lasts not more than 4 weeks. So whenever you're in doubt, you're not sure whether it is atherosclerosis or vasculitis, repeating a vessel wall MRI after 8 weeks, the enhancement persists, then it is strongly suggestive of vasculitis, because in atherosclerosis, that enhancement is going to go away. Does it really tell about disease activity? I don't think it does. There's no point doing vessel wall imaging to look for whether the vasculitis is active or bad, because we know that it can persist. Whether it can be used for biopsies, yes, it can be helpful, because usually brain biopsies the yield is low. But if you do a whole brain vessel wall imaging and target your biopsy, then the chances in this particular study was a 90% yield rate. So certainly for biopsies, it may be helpful. So one of the things that I really want to emphasize is this. A lot of the discussion, most places occur based on T1 pre and post. If you see here, there is this arterial wall which is enhancing. In this, if you see, this is almost 3/4 of the wall is enhancing. This is the M1 which is stenosed. But if you see here, this is the T2 imaging. Looking at the T2 is key to differentiating atherosclerosis and vasculitis. If you see this bright area here, adjacent to the lumen. So we call it a juxtaluminal T2 hyperintensity. And if that is there, then it points to atherosclerosis. It is not vasculitis. And this is one of the important take-home messages. So why this is important? Rarely vasculitis can be eccentric and atherosclerosis can be near concentric. Coming on to RCVS, the medial wall really thickens. There is an increase, 5-fold increase in the medial size. Normally, it's a smooth concentric narrowing. There is no enhancement. It usually resolves in 3 months. So, looking at the 3 attributes, ICAD, vasculitis, and RCVS, you have to look at T2 imaging to ensure that we are not missing atherosclerosis. As I mentioned, a lot of these vasculitis reported cases are actually atherosclerosis, not vasculitis. So, the T2 hyperintensity is present in 80% of ICAD patients, but absent in vasculitis and RCVS. And it's eccentric thickening in ICAD. The rest of them are near concentric or concentric thickening. And contrast enhancement, vasculitis is very avid, grade 2. In ICAD, you can have both grade 1 and grade 2. In RCVS, usually a grade 0 or grade 1 enhancement. Coming to moya disease, I know we have discussed this. The intima thickens, the media atrophies. Overall thickness of the vessel wall does not change, but it is negatively remodeled, meaning the outer diameter of the artery is lower. So that's what I've said, intimal hypertrophy. It becomes double the size, media becomes half the size, and outer diameter progressively decreases. And usually there is absence of enhancement, but we can see some grade 1 enhancement in moya disease. We know that nowadays we have been using it for aneurysms also. Say, for example, if a patient has multiple aneurysms, has a subarachnoid hemorrhage, we don't know which one has ruptured, we can do arterial vessel wall MRI to look for wall enhancement. And if there is wall enhancement, there is enough literature to suggest that that is a ruptured one. So if you see here, we call it as CAWE, circumferential arterial wall enhancement, in actually aneurysmal wall enhancement. If there is circumferential aneurysmal wall enhancement, then there is a high risk of that aneurysm being ruptured. So if you see this aneurysm here, the wall is thickened, and if the thickening is more than 1 mm, and if there is contrast enhancement, then that aneurysm is likely to be unstable or the ruptured one. So look at this patient with diffuse subarachnoid hemorrhage. If you see there is blood here, the right side also, left side also. There's a PCOM aneurysm on the left. There's a PCOM aneurysm on the right as well. So what they have seen is looked at the vessel wall imaging. If you see the left aneurysm here, there is thickening of the wall and enhancement of the wall. Whereas on the right, there is no significant enhancement. There's some focal enhancement, but not a circumferential wall enhancement. So clearly this one is ruptured, and therefore treating this would be adequate in this particular instance. So in multiple aneurysms in patients with subarachnoid hemorrhage, it has been of help. And we have seen this arterial wall enhancement post-intervention also, meaning that there is endothelial denudation or disintegration post-stent deployment that we have seen. So this is the wall enhancement that we have seen in patients who have underwent thrombectomy. So some of the pitfalls that have already been mentioned by my previous speaker is that one is be careful about one is the proximal segments of the intracranial arteries. So that enhancement can be actually normal, and calling vasculitis based on that is not appropriate. Second thing is slow flow will mimic as if there is eccentric wall enhancement. So wherever there is slow flow, you have to compare. So you may have to have a contrast luminal imaging to be sure that there is nothing underlying. And sometimes you have these veins on the along the wall of the artery, and you may see these parallel sort of structures that goes along with these arteries that are enhancing, and you may mistake it for vasculitis, whereas these are the veins that are accompanying the arteries. So going on to this particular case, so what do you think? 43-year-old male with no risk factors. Do you think it is some form of aortoarteritis? There is involvement of bilateral renal arteries, there's subclavian involvement, and of course in aortoarteritis you don't get intracranial involvement. So, and this patient was reported as vasculitis. Let's look at the vessel wall imaging in greater detail. So what is happening is, clearly we repeated the imaging at our center, so clearly there is an eccentric thickening and wall enhancement, if you see here. Okay, so this is this itself, and if you see it's the anterior wall of the middle cerebral artery, and because the middle cerebral artery has a curvature, and many times it is concave anterior. And if you look at this T2 imaging here, this is very, very important to look at this. This is the juxtaluminal T2 hyperintensity. This is a giveaway. So this enhancement is in the anterior wall, and in the anterior wall you see this fibrous cap sitting there. So this has to be atherosclerosis and not vasculitis. So we reverse this diagnosis as atherosclerosis. So this is that T2 juxtaluminal hyperintensity I'm talking about, and we decided that it is atherosclerosis. If you see, there's extensive calcification on the CT aortogram, which is not actually, unless you have some axial imaging, will not appreciate it. And this patient, we went ahead and stented, and there was good antegrade flow. Now look at this doctor, who is again 35 to 37 years old. I don't remember her. So she has a tight M1 stenosis. If you see the angiography, there's a tight stenosis here. But even in this angiography, it is very clear there is some eccentric narrowing. So the upper wall doesn't seem to be involved. But if you see, the inner wall is involved, the lower wall. Again, if you see here, the curvature of the artery is like this. Okay. So whenever the curvature is like this, we know from the flow dynamics that this wall, the plaque will deposit on this wall. It's not going to deposit on the superior wall, because we know the shear stress on the inner wall is less, shear stress on the outer wall is high. So it is following all the flow dynamic pattern. Even in the previous case in the middle cerebral artery, it is following all the, because the anterior wall is usually concave. And in that wall, so this is the concave part of the arterial wall, and this is the convex part. Usually you see it on the concave wall. And again, it's clear here that it is eccentric. and we did a vessel wall imaging. If you see here, this is the plaque that is in pre-T1. If you see, this is the plaque here, and this is the enhancement that is clearly eccentric. So we know in this particular doctor, although no risk factors, we know it is atherosclerotic plaque. We are not going to put this patient on steroids. And we know, if in doubt, if we repeat the vessel wall MRI after 8 weeks, this enhancement is going to go away. Okay. Now look at this patient, 47-year-old female, loss of consciousness, altered sensorium since 1 day, infarction, bilateral frontal lesion. See, if there is involvement of the terminus, there is involvement of the M1, maybe some involvement of the A1 also. But again, the important factor I want to see, one of the problems here is when you have terminus involvement, A1 and M1 involvement, we tend to think that it is not vasculitis because so it's not atherosclerosis. Usually when you have the terminus A1 and M1, we think it is more towards vasculitis rather than atherosclerosis. However, the vessel wall imaging suggests something else. If you see there is eccentric thickening and wall enhancement, and the most important thing is looking at the T2 sagittal image. Again, you see this T2 fibrous cap sitting, which is juxtaluminal, meaning adjacent to the blood. And beyond that, you see this black area here. This is the lipid core of that particular plaque. Okay. So, so one other important thing we found in this particular patient, we also looked at the plain T1. So if you look at the plain T1, there is a little bit of hyperintensity that you see. So this is a intraplaque hemorrhage. So this patient, although had terminus involvement, A1 involvement, M1 involvement, we know from the plain T1 there is some hyperintensity. That means there has been an intraplaque hemorrhage. And post-contrast T1, you see eccentric thickening and wall enhancement. And on the T2, there's a very confirmatory thing that there is a T2 hyperintense juxtaluminal hyperintensity, which suggests it's a fibrous cap. And the enhancement actually corresponds, this enhancement is actually the enhancement of the fibrous cap, this circular thing. Now, one other important thing is we need to know, we have to be very careful. Even the presenter earlier on looked at the cavernous part of the ICA and was showing that there is enhancement. Cavernous part of the ICA can enhance because the cavernous part of the ICA has vasoviscerum. So we cannot go by that. So this patient was reported as vasculitis on imaging. But is it? So if you see here, this is, if you see there is enhancement of the arterial wall. So this is the ICA. This is the extracranial ICA. You will normally see this enhancement. But this part here, this is the intracranial ICA. Here you should not be seeing enhancement, provided this patient, if it is 70-year-old or 80-year-old, this enhancement in the proximal supraclinoid ICA can be normally present also. So in this particular patient, we did a T2 sequence. Clearly, it shows that there is a T2 hyperintense signal, which is juxtaluminal, which corresponds to this enhancement here. But this patient was reported as vasculitis based on this enhancement pattern, which is concentric but is extracranial. So this patient actually had atherosclerosis and reported as vasculitis. If you see, this is the angiographic imaging. There's a tight stenosis. Went ahead and stented this patient. Now, looking at another patient, 35-year-old female with right-sided symptoms with no underlying illness. There's a, again, as I mentioned, terminus involvement, A1 involvement, M1 origin involvement. My first suspicion is vasculitis and not atherosclerosis. Now look at the wall imaging here. If you see, there is thickening of the arterial wall here, and there is, this is the axial imaging, this is the coronal imaging, so it is concentric, and there is avid enhancement, which is almost close to that of the pituitary stalk. So if you have a circumferential arterial wall enhancement, which is close to that grade 2 enhancement, then it goes for vasculitis. Now you see at 7 months, we have done a follow-up MRI, again this enhancement persists. So you cannot base your treatment on vessel wall imaging. The enhancement can persist for a long period of time. Now looking at this 37-year-old female, right-sided weakness and slurring of speech since 2 days. If you see, there is terminus involvement, M1 and A1 involvement. Now looking at this imaging here, this is the, if you see here, there is clear thickening of the wall of the artery, which is circumferential and very avid enhancement, almost that of a pituitary stalk. There is no doubt here. It was reported as focal cerebral arteriopathy. So important thing is 90% of the time when you think it is vasculitis on imaging, it is not. So you have to be very careful reporting vasculitis. Overlaps are not uncommon, meaning atherosclerosis, we always say it is eccentric, 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 but it can be near concentric. So what is the way to know? You have to look at the T2 sequence. Looking at the T2 sequence will help you differentiate vasculitis from atherosclerosis. If there's a juxtaluminal T2 hyperintensity, it goes to atherosclerosis and not vasculitis. If ever you're in doubt, then almost always just repeat another vessel wall after maybe 2 months or so. If it is atherosclerosis, the enhancement would have gone away by then. Extracranial vessels will enhance, will show concentric enhancement. Don't call it vasculitis based on that. So this one is a moya moya where there is negative remodeling with very minimal enhancement. This is vasculitis. If you see all three layers are enhancing. This one, even before any contrast, there is wall hematoma, right? So this goes for intracranial dissections. And the last one, prior to contrast, there is no T1 hyperintensity, but post contrast, there's an avid contrast enhancement. This goes for atherosclerosis.